Good afternoon. I am Susana Koppelman. Welcome on behalf of SEGIR to this exchange session, the first for 2023. As you know, SEGIR has the determination that has been maintained since its inception in dissemination of knowledge, sharing, and applying new technologies. So virtuality has permitted to share with the best speakers about the new technologies, new concepts, and today we will have the opportunity and the pleasure to share with two excellent professionals that work in a leading laboratory in the field of genetics. The exchange session will be around PGT with proposals and new challenges, and PGT for polygenic diseases. So it'll be very interesting. Thank you for your kindness, Jennifer, Diego, who will be introduced later. Again, let me tell you about the modality. We will have the presentation of the two presenters and then a panel for commentators, excellent level, who will enrich us with comments and some questions. And then we will have about 30 minutes for comments and also from the audience. So any question, comments that you would like to make, you can do it in question and answer icon, and Andrea Cosia and myself will communicate to the speakers and panelists. This is a symposium with simultaneous translation, so you can select your language in the icon that looks like a globe that says interpretation, the language of your preference. So I think there's nothing missing. So my Dr. Andrea Cosia will make the introduction. She's a specialist in reproductive medicine, coordinator of a fertility program, of the cryopreservation program, the director of the fellowship program of SEGIR. I'm a member of the executive committee of Summer. Andrea, you have the floor. We can start with the presentation and the speakers. Thank you, Susana. It's an honor to be part of the exchange sessions. I will have the honor to introduce, first of all, our speaker, Diego Marin. He is the head of clinical development and research of a prestigious genetics laboratory in genomics provision. He is genetician, deputy director of the laboratory, editor of over 6 articles in peer review articles. Diego, it's an honor to have you here. He will talk on proposals and challenges of PGT at present. So thank you, Diego, you have the floor. Thank you, Dr. Cosia. I share the screen. Can you hear? Thank you for the invitation. Today, the purpose of the presentation is where we are with PGT today and the approach we want to take is positive aspects where we are addressing that maybe bring benefits to the patient. And so the laboratory is moving that direction. And we want to talk about challenges. I am not going to say good and bad things, but having an optimistic approach and what PGT proposes for the future and challenges we have to face. My disclosures, I am a full-time employee of genomic prediction. And now beginning with the positive aspects, what proposals does PGT offer? I would like to focus on 3 aspects. The first is something that we stress, and we will not spend so much time streamlining optimization of PGT platforms. It's something we have to continue working on. And then PGT beyond the conventional indications, aneuploidia, monogenic, structural. In 2023, this is almost, although there is controversy in some centers, it is taken for granted the applications are a fact. So what is there beyond that? And finally, the trendy topic, uh, artificial intelligence and PGT, where can have a fundamental role, beginning with the positive aspects, optimization of the platforms. So the PGT platforms, as we have said several times, are very different in different centers, different chemistries. It's very important to know where we are going. What do we have to work with? One of the main points is the number and quantity of data resolution. This is a schematic that talks about the history. Of course, it doesn't include fish. It's basically molecular analysis of aneuploidy. But it's like how platforms have developed. So we started by seeing 4 positions in the genome per chromosome with qPCR, and then arrays like TNGS, where there are 20,000 positions in the genome. And then we have other platforms like SNP microarrays that have more resolution because they genotype 800,000 probes in the whole genome. So you can see that in 6-7 years, the resolution of PGT has increased almost 80-fold the amount of data, the number of data. That's important. Now, what do I want to stress? That one of the objectives that PGT platforms have developed is to incorporate SNPs, poly, single nucleotide polymorphisms. They are very useful because they open the door or a window to a lot of information that we didn't know or we didn't know was in the trophectoderm biopsy. This is not the purpose today, but just to mention that it permits to detect many things. For example, polyploidies that we couldn't do the resolution to identify false negatives or positives of PGTA that sometimes with the chromosome dosage we do not see. So this is one of the main objectives. Now, I do want to stress that although the SNPs microarray, because of the name, gives SNPs data, having that extra tool of single nucleotide polymorphism not only use the SNP array, there are next generation sequencing platforms that are incorporating it. So it is something that is relatively, if we want, it's simple to use, it's only changing the chemistry, amplification methods. But yes, I want to say the SNPs not only are exclusive for microarray, but many next-gen platforms are incorporating them to a lower extent because of the limitations of the platform, but we go in that direction. So one of the proposals that PGT is giving us to obtain more information. Now, the other point is validations and clinical results. About validations, it's something else that is very important. That at the beginning, when the first PGT tests or the first clinics in the US were established, very few validated a platform. More recently, with more elements, now we begin to see quality standards of each laboratory, of what experiments you have to do to validate the PGTA platform. In the past, we would buy cell lines that had a certain karyotype. Trisomy 18, we would run them in PGT, obtain the expected result, and that was it, validated. Now we know it is not sufficient because one thing is we can see the sensitivity, but no specificity. So I don't want to go into detail with these terms, but yes, I recommend this article by Juno Group. Um, in James Jalas, Dr. Sely make a good description of the standards, quality standards to validate the PGT platform. But what I am interested in is are the clinical results. because in the last 5 years, at the beginning, we couldn't do a type of studies, but now we can because we have a lot of data and many people doing PGT in different ways. And the type of studies I am talking about is when one laboratory of in vitro fertilization uses different PGT platforms. And that is very important because this year, I think, ASRM, not so much this year, but there will be a lot of data of this type in ASRM. So there are studies in which a PGT laboratory, IVF laboratory controls the laboratory biopsies. And finally, what we do is simply comparing the clinical results depending on what PGT laboratory is sending in. Why do I stress this? Because the differences are dramatic. Differences are not only because of the technology used, but also sometimes simply because of the quality standards each laboratory has. So although these may be interpreted as a challenge, we use it as a proposal because the purpose is that those clinics that have the resources that before choosing a PGT platform attempt to do these studies because they may take surprises with platforms they use and they didn't know the chemistry of others. Now, this is simply talking about, as a genetist, now about the clinical application and what is PGT offering today to go beyond. And this goes hand in hand with the idea of the resolution to take as much information from the trifecta and biopsy. One of the advantages is what is known as the witness, genetic witness. This is a tool for quality control and safety in the laboratory. So what is this about? It's a, when we take the PGT biopsy, we do the analysis to give the karyotype, adding data, as I mentioned, of polymorphism, of a single nucleotide elasticity of data. It permits to compare the similitudes of two trifecta biopsies, or how similar is this biopsy with the DNA of the father and mother. So why is this important? Because it becomes a tool to avoid errors in the laboratory, in the IVF laboratory, rather than avoiding identifying it and then taking action. We know many studies of systems witnessing matcher or barcodes, and they are very useful. But if there is an error upstream when I am placing the label, the error will be dragged to the end. And if we don't have a tool like genetics, it never tells lies, well, we couldn't have detected the error. So this is an advantage. I bring some data from Diana Garro, who worked in a study that is under review. And this just to illustrate how this genetic witness can be applied. So what was done in this study, what is about to be published, is in a PGT routine laboratory. How do we identify this? So in panel A, we are observing 96 samples of different patients, trifecta and biopsies, and samples are DNA from father and mother compared to themselves. So this is the X. So it's a comparison of all the samples to themselves. So we have the heat map. So what this is telling us is that each sample compared to itself indicates that it's the same genetic origin. And these red squares indicate that those trifecta samples have higher similitude than other samples. When we have a low similitude, then you see the clearer color. And what is interesting is this correlates or indicates that each one of these red squares is a cohort, a different patient. So it's not only give, we not only give karyotypes or genetic diagnosis, but we are giving extra quality control, making sure that the samples are all from the same patient. And in case of having parental DNA, we can confirm paternity with the DNA that is sent. So Diana is giving us an example of a cohort. What I said, this represents the same sample. These are brothers. And then here, two father and mother samples that are not related because they are a couple. And here in C, Diana illustrates when you see an error. So in this case, the embryo 6 of this cohort is an embryo that was, was not supposed to be there. So this just to illustrate how to use this tool. How else can we go beyond PGT, AM, and SR? Complete whole genome sequencing. I don't know whether you had the opportunity to attend this meeting in Paris, um, where we talk about what is new, and Dr. Mune presented a pilot data on using whole sequence or whole genome sequencing uh, to to identify mutations, de novo mutations. So we are going beyond aneuploidy, but we are seeing the whole genome. Obviously, we talk about something new that is still incipient, but quite promising. So it is possible that in a few years, the biopsy can be exploited because we are doing it to get as much information as possible, and perhaps the information has other implications too.
And finally, beyond the aneuploidies PGT, M, and SR, we have other biomarkers. That is to say, not just to detect DNA, but also go beyond. And in the biopsy, apart from PGTA, we can have data of genic expression, messenger RNA, proteins. So we published a proof of concept, and out of the same biopsy. This is very important because there are some other groups that have done similar studies, but with separate biopsies. There's clinical application with just one biopsy, and we have to make sure that we're not bothering PGTA. That works perfectly well, but within the same chemical reaction, we can provide a profile of the genetic expression. We had a proof of concept, and the Canadian group also replicated something similar to that. So this is just to say that not everything is PGTA, and we can have other markers as well. Regarding epigenetic markers, to my knowledge, I know the Army New Jersey group with Dr. Sally and Dr. Scott attempted to have a methylome profile with just one sample, with just one biopsy. It's clear that when you do that type of, so many chemical reactions in just 6 cells, 50 microliters, well, it's quite difficult to do. And even more so, well, you need to make sure that PGTA is not affected, because I remember in these experiments when we tried to do epigenetic markers, we perform the bisulfide conversion, but the message is that there was a problem with PGTA. So we need to recollect or gather the most that we can get from that without having to do a second biopsy. And to conclude on this, what is PGT giving us so far is the issue of artificial intelligence. Artificial intelligence is something that will revolutionize IVF in our daily practice. And the takeaway message is that what is it that you understand with, or when we talk about AI? We've seen several centers, well, not many, but some centers who are marketing a lot of tests through AI, just simply providing an algorithm that predict karyotypes without human intervention. So a PGT lab has a lot of biopsies, And so they have a training set. We have biopsy samples and clinical results. They know that this sample or this specimen will have X amount of results, and they use that to create an algorithm, and the algorithm will automatically calculate a result. But this is not exactly AI. This is just a tool to avoid bias with a PGT lab. But the AI goes beyond this, because what we're trying to show with this picture is to have score with a lot of different aspects considered, not just the PGT results and the biopsy. In our field, this has to include several other aspects: genetic profiles of the parents, morphokinetics, the PGT result. Remember that despite the fact that we get a PDF or a piece of paper with a karyotype, the valuable data are behind that. That is to say, the reading through sequencing, or the SNPs that we are genotyping through microarrays, and we need to relate this to our clinical results. So with the holistic vision of the data of clinics that have a lot of cycles, then we can put into practice AI together with PGT, and this will provide prediction with a higher level of certainty in specific embryos, or even when the patient comes to the clinic. What we know so far, well, we know that there are several centers that are trying to do with what I just described with the PGT data to provide an algorithm to avoid bias. But today we have not seen a center that does a holistic approach. However, I had this experience. I was able to work with this company, Circle AI, and they are doing exactly what I just described. This is a company, a startup in the last 6 months, and what they're trying to do in USA and Europe to get in touch with IVF centers that have morphokinetics, parental DNA, PGT, and you know, they are contacting outsourced PGTs, not in-house. However, what I want to say that this exists. I have no disclosures to make. I just got in touch with them because I thought it was a valuable tool. And if you have any interest, you can do the research. I know that there are a lot of, they're trying to look for collaboration with other IVF centers. And I think that this is promising in the future to optimize PGT. I was a bit fast because what I'm trying to do is to focus on the challenges of PGT today, specifically one, which is something that, and if you are in agreement, I would like to talk about segmental aneuploidies. We consider nowadays the elephant in the room. This is one of the things that we do not talk much about, although we get a lot of questions about it. So just to give you a concept of segmental aneuploidies, it's when we have a snippet of the chromosome with a deletion or a duplication. And this is an example of a trophectoderm biopsy with this karyotype. And this is the visualization of chromosome 10 through the SNPs microarrays. This is chromosome 10. This is the short arm. This is the long arm. We see the number of copies. You can see in the short arm, for the number of copies, you see like a highlight in the signal. This means that that's a duplicate. And below, you see a distortion of the SNPs that confirms that there is a duplication. Why do we say that they are a problem, that segmental ones? Well, segmental ones are a problem because we're not very familiarized with them, at least in the big centers that have carried out these types of studies. They talk about a prevalence of 8 to 10% or 5 to 10%. That depends on the technology, but that's around it. We are talking about embryos with these types of segmental aneuploidies. And these are the papers that summarize this that I'm talking about in case you want to read them. But the important thing is the origin of the segmental aneuploidies and why they are a challenge. I would provide an example of an embryo that we rebiopsed. These are discarded embryos. This is biopsy number 1, chromosome 11. The rest of them had no distortion, but in chromosome 11, in biopsy number 1, we saw a deletion of this little snippet of the short arm in chromosome 11. This is biopsy number 2 in the same embryo. We see the same deletion. I don't know whether you can see here that there's, some dots that were, when there's a deletion, it should be completely white, no heterosity. On biopsy number 3, chromosome 11, it's similar to biopsy number 2, but the interesting thing is to look at biopsy number 4 and 5. Biopsies 4 and 5 could have been euploid perfectly fine, because if you had performed the biopsy in that sector. So, one of the biggest challenges of segmental PGT is that most of them are mitotic in origin. And this is something that we managed to reproduce with the Mandy Katyafi study. And if I'm not mistaken, almost 85% out of are of mitotic origin. So this is what makes it so difficult, because, we're talking about a biopsy, and if we have no prediction tool, then it's impossible to know. So to conclude this part, one of the biggest questions that physicians ask us is whether we should transfer these embryos. And I think that, well, at the end of the session, we can ask Sebastian, Cecilia, and Jennifer, because in our criteria, well, this is a relevant issue. When we talk about aneuploidies of whole chromosomes, the predictive value is very well established through non-selection studies that have been published. And nowadays, I think there are only 2. We know that when there is aneuploidies, a whole aneuploidy, the value is of 1. If it implants, it's a syndrome. But what about aneuploidies? Well, why not? Why don't we have any studies? Well, because it's a very low prevalence. It's less than, it's very difficult. The non-selection study is when you do the biopsy in the embryo, you freeze it, you do not process it. The biopsed embryo is transferred. And then when I have the clinical result, I analyze the biopsy. It's an excellent experimental design for predictive value, but with a 10% prevalence of segmental aneuploidies, it's very difficult to do this. To have patients in these types of studies is very expensive, and that is one of the main reasons why we haven't done this. But until we don't do it, then we will know about the predictive value of whether these segmental aneuploidies have a compromised clinical outcome. So geneticists might then answer this question. And the last one that I wanted to talk about, and this is something we get often when we started working with PGT, whether aneuploidies were real. Do I have to believe this or not? Initially, you say, well, of course you must, because this is what we see. However, we've seen several meetings and think tanks on PGT, and we've seen, or there is an observation that shows us that there are certain regions in chromosomes, certain sites, where we have replication, DNA replication. It's what they call hotspots, or replication origin hotspots, fixed positions in the chromosomes where DNA starts replicating. So there is a chance, there is a probability that when you see some segmentals, not all of them, because the rebiopsies that I showed, there were segmental, but it is possible that some of these segmental aneuploidies are artifacts of technology. We don't know the prevalence of this, but we've seen some correlations between where they start and where the replication genetic hotspot starts, which is a natural process that occurs in the cells, and this can correlate with some segmental aneuploidies. And that is why I leave it at that for you to think about. It's something that we are trying to do research on. It's a big challenge because, of course, this is something that you see in the PGT reports. And to finish, because I think that a promising part of PGT is PGTE, which is an important thing, and this will be talked about later on. I want to talk about PGT heterogeneity and accessibility. When I say accessibility, I am referring to patients. In other lectures, we have shown this slide. This slide is very important for us to be aware of, and especially to understand it, because as I said at the beginning, PGT is a concept, but the way you perform PGT, well, that can vary. And because it's such a recent thing, and the FDA is not regulating, anybody can do whatever they feel like doing. So it's not a bad thing. Sometimes it's positive because we can make faster progress. But the thing is that we can have different criteria and standards. So this ends up generating a lot of confusion. So what happens? We have high variability of aneuploidy rates and clinical results. This is what I said before. It's important for you to do benchmarking of clinical results, comparing different platforms. Published studies with different messages or conclusions. We have some non-selection randomized that say PGT is great. And then we have a multicentric randomized, such as the STAR trial, that says that in patients from 30 to 35, it has no benefit. So if you read that paper in detail, you will see that the experimental design included a lot of laboratories with different mosaicism reporting standards. So this there are some RCTs that are not so truthful in the way they are publishing their results. And this, of course, has to do with the independent management of concepts such as mosaicism or mitochondrial DNA. Each of the labs have their own standards. And why is this a problem? Well, this is a problem because at the end, the field, when I say the field, I mean our colleagues, our peers, and our governmental institutions and regulators and insurers do not believe PGT is a good tool. And because they do not believe in it, just because of heterogeneity, well, this brings about a problem with accessibility for patients, because we have physicians that are not offering it because they do not believe in it. And so patients will not have that information. I don't know whether this happens in Argentina, but we have a lot of patients forums. They talk about mosaicism, but there's no good information. There's a lot of fake news. So this is just to conclude my lecture, because this is a challenge for us. If it was a more homogenic industry with a regulator and someone who regulates standards and clinics, then we would have one single message to convey, and we would have the insurers and the governments on our side to offer PGT free of charge, considering all of the benefits it brings about and considering that it's not so expensive. So this is my message today. I hope that then in the Q&A session, we can continue talking about it. And of course, this is my contact information if you want to get in touch with me.
Excellent. Thank you very much for your presentation. It's been very good. Excellent presentation. I liked your approach. Congratulations. We'll be looking forward to the questions and, of course, Cecilia and Sebastian's comments later. Thank you. Now we will continue with Jennifer Eccles. She is certified in genetic counseling, responsible for genetic counseling on genomic prediction, and has over 20 years of experience in reproductive clinical genetics. Jennifer will talk about something very interesting, that is PGT for polygenic diseases. Jennifer, welcome. Thank you very much, and you have the floor.
Thank you so much. Let me share. Can you see my slides?
Yes, I can see it.
Excellent. Okay, fantastic. So thank you so much for having me. And I'm very happy to bring you polygenic testing and how it pertains to the IVF setting. And like you've just heard, I'm a genetic counselor, and so I'm going to speak really from a clinical and counseling perspective when we talk about this subject, which is really the only way I know how to speak about this subject. And so first and foremost, I wanted to talk about the current use of PGTP. What does this look like currently? If you were to order this testing, or if you're a couple going through IVF, what type of report are you going to be getting through our laboratory if you wanted polygenic testing? And so the report will look something like this. And polygenic testing in general, as it pertains to embryos, is screening embryos for certain conditions that are influenced by genetic changes in many different genes. And those conditions are further influenced by non-genetic or environmental factors. And the combination of all of those things together are what influences our risk of developing these conditions over the course of our lifetime. So part of the reason people may be interested in polygenic testing is because it can be a tool used to help decide which embryo to prioritize for transfer. And so that's how our reports are really set up. So if you look at this report, you'll see the embryos categorized first and foremost, and most importantly, by ploidy status, so PGT-A testing first. So the first group of embryos are the embryos identified as euploid. The second group of embryos are the embryos identified as aneuploid, and you can see the different karyotypes listed as well as the embryo sex. It's this last column that's different on reports that include polygenic testing or PGTP. And in this column, on the first page, we report what we call an embryo health score. That's our nomenclature for describing a number that takes into consideration all of the different risks that we screen for using this testing, and putting it into one single number so that you can get a bird's eye view essentially of the risks for those conditions in that embryo. An absolutely average risk is a risk of 0. Anything above 0 is better than average, and anything below 0 is poorer than average. The goal of the testing is not so much to learn what the specific number is. Rather, the goal of the testing is really to be able to say, if we have a group of embryos and we're looking at them all together, which embryo in the cohort has a lower risk compared to the other embryos. And so on this report, the embryo with the best embryo health score is embryo number 4, and that's listed first. So if somebody quickly said to me, okay, we have the report, which embryo do we prioritize? We can look quickly and say, okay, well, let's focus first on the embryos that are euploid. And then we go, okay, the best embryo health score is embryo number 4. That's the embryo we would prioritize for transfer. And then we would go to the next embryo and next embryo and next embryo. On the back of the report, in the next pages, for each embryo, we provide additional information. And the goal of adding this additional information is that some couples are interested specifically in looking at specific risks for particular conditions that they may be more concerned about. For many people, the information on the front page may be just enough. But if that isn't enough, we give specific risks for specific conditions that are included in the panel of diseases we screen for. Things like type 1 and type 2 diabetes, certain cancers like breast cancer, malignant melanoma, basal cell carcinoma, cardiac risk factors like heart attack and coronary artery disease, asthma, schizophrenia. If this were a male embryo, instead of breast cancer, we would have reported testicular cancer and prostate cancer. But either way, we list these particular conditions, and then the first column gives the actual risk that's estimated in that embryo based on the polygenic risk score data. And then the next column, we provide the average risk in the population. The first column is really meaningless if we don't have the second column and the rest of the information. So for example, for type 2 diabetes, this embryo's risk is around 34%. The average risk is around 32%. So that lets us know that the risk in this embryo is essentially average, maybe slightly higher. The ratio and the risk percentile are also additional pieces of information so that you can help gauge how far off the risk is compared to the general population. So a ratio of 1 means that it's perfectly average risk, and a risk percentile in the 50th percentile means that that embryo is exactly in the middle of that bell curve for risk and is right exactly average. So when clinicians ask me, or when patients ask me, who are the individuals that may consider PGTP? In essence, this testing is really designed for individuals who are already going through the IVF process and who are already considering and decided on having PGTA. So PGTP should be considered as an adjunct, as an additional test to PGTA testing for couples that are already through and going through that particular process. One of the other big questions that I always get asked is it important to have a family history of one of these conditions in order to be considered for this testing or in order to order this testing? And the reality is that's not necessary. We all have risks for these conditions. We're all at risk for these conditions. So having a specific family history is not necessary because we can calculate these risks without that information. And that is how we do this testing right now. The family history is not actually a piece of the puzzle when it comes to what information is taken into consideration. So anybody can add this information into their testing plan if they wanted to, if they felt that that information would be beneficial in terms of making a decision. With that said, though, certainly if somebody has a particular history of a particular condition that's worrisome, it may come up more frequently, or you may get asked more about the possibility of this testing. And the situation that comes up clinically in our lab all the time is patients who have a known history of conditions, specifically type 1 diabetes. So our families where they already have a child with type 1 diabetes, or maybe mom or dad has type 1 diabetes themselves, we get a lot of inquiries based on that specific history on whether PGTP may be right for them based on that. Now, if we get an inquiry about a specific condition that's on our panel, and in talking to the patients, it feels potentially like there's a strong family history suggestive of a monogenic condition, that's a little bit different. So for example, if I'm in the course of talking to one of my patients, if they say, you know what, I'm interested in polygenic testing because I know that breast cancer is on that panel, and my mom had breast cancer when she was 50, and my sister had bilateral breast cancer at age 42, and I have an aunt with ovarian cancer. Well, to a genetic counselor, this screams monogenic cause of disease. And this is that's a classic example of when we would start to think about inherited variants that can be associated with cancer syndromes. And so in those cases, PGTP really is not the first line of defense at all. And PGTP is not a replacement for PGTM. Rather, those families should be evaluated in the same way, consistent with whatever the concern is. So if I'm presented with that history, the next step is, well, has there been any hereditary cancer screening offered to you, offered to family members? And that should actually be the first step. Because if there's an inherited cancer syndrome in that family, let's say a BRCA1 or BRCA2 variant or something else, then actually PGTP does them no benefit. It's really PGTM that's the proper test to address their hereditary risk of cancer. So it's very important that even though PGTP is available, that it not be considered a replacement for PGTM if there seems to be some overlap with a condition that, may be on the panel, but also, in theory, may also actually have a monogenic cause. Type 1 diabetes also, as a side note, falls into that category. There are inherited, they're rarer, but there are inherited forms of type 1 diabetes, like maturity onset diabetes of the young. That's a dominant condition. So it is important to be able to feel those things out and really take an informed history when we're making the decision about whether to offer, certain testing. Another question I get asked all the time is, does it matter how many embryos a patient has? And the answer is yes, it actually does, which is very different than other types of, PGT. If you're going to do PGTA testing, because results are essentially analyzed individually, it doesn't matter if you have 1, 3, 10, but the fidelity of PGTP testing actually does depend on how many samples we have to look at, because it is a tool for comparison. And I can't stress that enough. So if there's a couple sitting in front of you and patients, 40 years old, and
Se le cortó a Jennifer, Andrea.
Déjame y reviso rápidamente.
Hola, puede ser que tengamos una interrupción.
Sí, ya voy a
Sí, se le cortó a Jennifer. Esperemos a ver si vuelve, Andrea.
Bueno, esperamos unos minutitos.
Acuérdense que tenemos Nueva York lleno de smog, entonces no sé si eso puede
Es
estar
cierto.
causando. Está fatal, pero vamos a
Nos
ver.
estaban contando eso, ¿no? Que
A ver.
por unos incendios en Canadá.
Sí. Can you again?
Sí, precisamente justo estaba contando eso, que estaba un poquito difícil la cuestión atmosférica. Bueno, esperemos unos momentitos y si no, quizás esperemos un poquito a ver si Jennifer se reincorpora.
Claro.
Y si no, cualquier cosa, empezamos si ustedes quieren hacer comentarios con Diego. Pero la verdad que estaba muy interesante la charla de Jenny.
Ay, sí.
Déjame, ya estoy confirmando. Por mientras les muestro en tiempo real el smog. O sea, no sé si se ve en mi ventana, pero
Bueno.
está fatal. Al final,
Sí, nos dijo.
no está muy bien. Anyway, déjame ver.
Si quieren puedo presentar a los discutidores mientras tanto.
Dale, Andrés, me parece bien. Así.
Sí, la gente ya los conoce, pero bueno, el público se renueva, diría.
Sí.
Así que, bueno, voy a presentar en primer lugar a la doctora Cecilia Fernández. Cecilia es bioquímica, especialista en genética, con un doctorado en biología molecular de la UBA, y es directora del Laboratorio de Genética Reproductiva de Novagen. Así que buenas tardes, Ceci, y bueno, en un ratito te damos la palabra para que hagas tus comentarios. Gracias por estar. También voy a presentar al doctor Sebastián Benassi. Él es médico especialista en genética y tiene una maestría en biología molecular. Bienvenido, Sebastián. Buenas tardes. ¿Cómo
Gracias,
estás?
André. Buenas tardes, ¿cómo están?
Un placer tenerlos hoy con nosotros, como siempre. Si quieren, podemos hacerle algunas preguntas a Diego o algún comentario. Él les dio la palabra, ¿no? Como que abrió ahí un buen interrogante, así que podemos comenzar con esto, si les parece.
Bueno,
Vos, Diego, no sé si estás en contacto con Jennifer. A ver
Sí,
si...
la estaba llamando porque a veces en Zoom uno sigue hablando solo.
Sí.
Sí,
A ver que no esté. Espérame.
Ahora no sé si querés, te damos un segundito para que te contactes con ella en todo caso.
Si quiere el público ir haciendo preguntas de algo, de todo lo que se habló, aprovechen. Este es un buen momento ahí en el chat. Tenemos
Por
80
ahora
participantes, así que muy bien.
hemos tenido más, algunos han ido yéndose a buscar un café. Pero bueno, todavía no tenemos muchas preguntas del público, así que si Jenny no se contacta en breve podemos arrancar, si ustedes
Arrancamos
quieren con...
nosotros.
Sí,
Si
dale,
quieres,
con algunas
arrancamos.
preguntas, comentarios.
Perfecto, perfecto.
Pues,
Bueno, arranco yo, Seba. Perdón.
Dale.
Diego, me encantó todo lo que planteaste. Me parece que algunos son temas que un poco se dejan de lado o no se discuten porque son un poco escabrosos a veces,
sí.
pero que ya estamos en un nivel y con una experiencia respecto a PGTA con las distintas técnicas que se utilizan en las cuales ya hay que empezar a abordar estos temas. Hay que empezar a prestar mucha atención en la validación, sensibilidad, especificidad del método, qué valor predictivo va a tener. Así que me gustó todos los temas que fuiste exponiendo en la charla y que dejaste ahí un poco como...
Claro, los tiré todos puse
Los
toda la
tiraste
carne en el
todos,
fuego.
bueno, fue una bomba de temas que darían para profundizar cada uno muchísimo. Así que te felicito porque la verdad me gustó mucho, sobre todo poder tocar estos temas desde la parte más técnica, ¿no? Que es la que más me toca en particular. Tengo así distintas preguntas un poco técnicas, no sé si más o menos van a ir saliendo en el orden que vos lo fuiste diciendo. Creo que comenzaste un poco con este tema de PGT y la validación, y que inicialmente se hizo con líneas celulares, pero que ahora eso ya está quedando corto. ¿Podés profundizar un poco más a qué te referís con que va quedando corto? Porque sabemos que el material óptimo a usar sería una biopsia de un embrión en el cual supiéramos lo que tiene, pero eso no es factible de hacer. Entonces se va usando como control positivo la mejor aproximación, en este caso líneas celulares. Entonces, un poco a qué te referías con eso, y si te referías a material biológico o en particular a otro tipo de estudios y validaciones que hay que hacer.
Claro, entonces, bueno, cuando hablamos de validaciones, hay dos tipos de validaciones que hay que hacer. Una es la analítica y otra es la validación clínica. La validación analítica es lo que hacemos los genetistas, ¿no? Que es ver que el resultado es igual al control positivo. Entonces, sí hay que comenzar con líneas celulares porque es algo muy factible de hacer. Cualquiera puede cultivar fibroblastos, cargar 6 en un tubito y pues correrlo, ¿no? Cuando digo, digamos que se queda un poco corto, se queda un poco corto también en material biológico. ¿Por qué? Porque, como dice Cecilia, es verdad que no es fácil conseguir biopsias de embriones, pero grandes centros o incluso pequeños que tienen embriones, qué sé yo, que ya fueron descartados con PGT, no solamente hay que limitarse a las biopsias, a las líneas celulares, sino también rebiopsiarlos, o sea, hacer picadillo de embriones. Eso es muy útil para validar una plataforma. Es verdad que existe el riesgo de mosaicismo, pero la ventaja que tenemos hoy por hoy es que sabemos que la incidencia es muy baja, ¿no? Hablamos de 3 o 4%, al menos en aneuploidías completas, porque sementales es otra historia, pero eso serían, digamos, añadiendo ese material biológico, ojalá rebiopsias de embriones. Esto es validación analítica. Luego viene la validación clínica, que es la difícil, la que no todos podemos hacer por recursos, que entran ahí los estudios como los de no selección. Estos estudios, yo recuerdo que cuando participamos aquí, eran estudios que le ofrecían ciclos gratis a las pacientes, ¿no? Para reclutarlas. Entonces, claro, ¿quién va a no tener o sea, no todos tienen esos recursos? Entonces, a eso es lo que me refería. Y también un poco, pues ya cada plataforma pues tiene sus métricas, ¿no? ¿Qué es ruido, qué no es ruido? ¿Cómo distinguir la diferencia entre ruido y señal biológica, ¿no? Entonces, eso, claro, depende mucho de calidad de muestra. Es importante también, si tenemos SNPs, hacer mezclas de líneas celulares para validar que podemos detectar contaminación. Porque, claro, una cosa es validación de cariotipos, de PGTA, Eso es bastante sencillo, pero luego las otras validaciones. ¿Cómo valido que mi plataforma en realidad me está detectando cohortes embrionarias? ¿Cómo valido que la plataforma? Entonces es simplemente buscar controles positivos para esas otras aplicaciones, pero digamos que más o menos era eso lo que me refería.
O sea que entiendo, ampliando un poco esto ya a ustedes y su experiencia para validar la plataforma de Array, entiendo que de esa manera lo usaron, digamos, tanto líneas celulares, lo hicieron, perdón, tanto con líneas celulares como con rebiopsias de embriones.
Para la analítica, sí, exacto. Y luego la clínica, pues es algo que sigue en curso, pero es un estudio que estamos intentando en no selección.
Ok, perfecto. No sé, Seba, si querés agregar algo, si sigo preguntándole.
Capaz mi comentario es más de clínico, de justamente cómo seleccionamos qué embrión con un mosaicismo y una anomalía segmentaria transferimos o no. Ese es un poco, quizá que para lo que me hablaste, Diego, hace un ratito. Yo voy a dar el punto de vista del médico genetista. Y los médicos genetistas estamos muy formados en totalmente el diagnóstico y en este caso lo que podría ser la prevención de anomalías congénitas, de defectos congénitos, de síndromes genéticos. Entonces, un poco el problema que se nos presenta, digamos, en el abordaje del PGT, justamente como bien Diego decís, el elephant in the room, de decir, bueno, ¿qué hacemos con estos embriones que tienen lo que en medicina reproductiva o en embriología podemos llamar anomalías parciales y lo que los médicos genetistas llamamos de lesiones o duplicaciones? Así que es un poco la forma en la que hemos sido criados los médicos genetistas, ¿no? Y acá se dan distintas situaciones. Y por un lado, digamos, o uno de los abordajes que generalmente, o por lo menos en lo personal yo tomo, es decir, bueno, la anomalía que estoy identificando, que se identificó en el embrión, es una anomalía que sepamos que tiene un correlato postnatal, ¿sí? O que un chico que tiene determinada discapacidad o síndrome genético tiene esa misma anomalía descripta o identificada. Entonces uno dice, bueno, si un embrión tiene una lesión del brazo corto del cromosoma 5, del brazo corto del cromosoma 4, sabemos bien los médicos genetistas que la lesión del 5P y del 4P pueden dar origen a síndromes genéticos conocidos. Entonces, un poco acá la lógica indicaría, bueno, si sabemos que esas células pueden mantenerse en el embrión porque pueden dar origen a ese síndrome genético, uno recomendaría eventualmente no transferirlo. Pero bueno, también se dan situaciones y que tenemos que tener en cuenta, como decir, bueno, ¿qué porcentaje de mosaicismo tenemos? ¿Sí? ¿Será que el embrión va a eliminar las células que tienen el mosaicismo y evidentemente después el chico no va a tener ese síndrome genético? Francamente no lo sabemos. Si es una anomalía que no está descripta, bueno, podemos suponer a partir de los miles de estudios de microarray postnatal que se han hecho en niños con discapacidad intelectual o síndromes genéticos, que conocemos la mayoría de las lesiones y duplicaciones que pueden dar origen justamente a anomalías congénitas. Pero la realidad es que eso tampoco lo sabemos y muchas veces será predecir en base al tamaño que tenga la lesión o la duplicación. Entonces, de alguna forma también hay un pensamiento circular, digamos, en cuanto uno dice, bueno, esta anomalía no está presente por el hecho de que es incompatible con la vida, entonces el embrión con el mosaicismo eliminará esas células, o no está presente, pero podría estar presente en un grado de mosaicismo, y tampoco sabemos si todos los niños que tienen una anomalía congénita pueden tener, mejor dicho, sabemos que algunos tienen mosaicismos y algunos mosaicismos de patología cromosómica estructural, entonces puede ser algo que no esté descrito o que sea menos conocido. Bueno, ahí es donde también tenemos que un poco hipotetizar en base al tamaño de la lesión, la ubicación. ¿Sí? Pero bueno, hay muchas complejidades en el medio. También sabemos que la mayoría de los síndromes de lesión, de duplicación, son microlesiones y microduplicaciones, que el PGT en los estándares actuales muchas veces no ve, porque vemos anomalías de más de 5 o de 10 megabases. Entonces, también ahí muchas veces tenemos la tranquilidad de decir, bueno, si es poco probable que una lesión de 20 megabases esté presente en un niño con una anomalía congénita, probablemente lo que detectamos como anomalías parciales en el PGT tampoco sea, ¿sí?, o pueda implicar ese riesgo a futuro, ¿sí? Pero bueno, la realidad es que un poco lo que quiero transmitir es que en esto tenemos más dudas que certezas, sin dudas, y que la realidad es que, por lo menos en el caso mío, nos basamos en esto, en qué sabemos de las patologías postnatales y de los síndromes de lesión y de duplicación postnatales, para poder eso justamente correlacionarlo a nivel del PGT. Del mismo modo que uno no transferiría un embrión que tiene una trisomía 18 en línea de mosaico, porque sabemos que la trisomía 18 puede dar origen al síndrome de Edwards, solemos hacer ese mismo ¿sí? Ese mismo tipo de análisis para lo que son de lesiones y duplicaciones. Pero bueno, esto es algo mucho más hipotético, mucho más teórico que algo de lo que realmente tengamos evidencia, ¿sí? Quizás lo que un poco a veces nos preocupa a los genetistas es que se suele tomar más en cuenta el endpoint de embarazo sí, embarazo no, y uno piensa, bueno,
Sometimes we take the endpoint, pregnancy or non-pregnancy, and this could be compatible with evolutionary pregnancy or a genetic syndrome. So this is where we have our major concern, even more so if you transfer embryos. Guidelines recommend to continue with prenatal studies. So we must also have amniocentesis, have some studies to assess mosaicisms, deletions, or duplications. So this makes the geneticists work even more complex to find these types of anomalies in mosaicism in partial alterations. And to conclude with this, and I see Jennifer is online again, and I had a couple of questions regarding partial alterations. Well, it's actually two. One is related to whether they're real or not. With your experience, do you have a cutoff value to believe in them more or less? You provided a rebiopsy example. Did you test this in how many embryos? I understand that you showed us one as an example, but in your research, how many embryos did you try it on to show that this is not real? Well, regarding your first question, whether they're real or not, well, that was one of the questions we asked ourselves. This was about 2 or 3 months ago. It's quite recent. You know that in congresses, the most important thing is to go out and socialize. That's when you learn the most. So we were talking with people in our field, and they were talking about the replication hotspots and looking at the correlations. There was the theory of the artifacts interface. However, whether it's real or not, based on the size of deletions, we don't have an answer for that because it depends on the chromosome, the SNP's density. It's not the same resolution in chromosome 1 or chromosome 19. In 1, we can have a megabase, in 19, 5 or 7. So this will vary according to chromosome. And regarding the other question, in our segmentals, well, it's difficult because it's only a prevalence of 10%, and we have some informed consents, and they do not allow rebiopsy. So out of 25 embryos, most of them are a male origin or parental origin, and then we have 5%, which is mitotic, so mosaicism. So you see what you saw in the example. It's under revision, but that's the data we have. And also, I wanted to say something else. What Sebastian was saying is that a lot of physicians ask us, please do not report segmentals. And if it's, if you're a PGT lab, it's an issue if you're not reporting segmental. That's why we say it's the elephant in the room. And that is why Jennifer and Cecilia and Sebastian will come to aid us. Thank you so much, Diego, for your detailed answers. And Jennifer, if you want, we can continue where you left off. You were cut off. Are you all right?
Yes, sorry about that. The internet, we lost ourselves. We're having bad weather and a little bit of craziness over here. So I apologize. Let me pull that back up. Okay. Okay, was I about? I think I'll start here just because I'm not 100% where I was. So I think that this way it'll cover it no matter what. Okay. So one of the questions that we get asked all the time is who should be offered PGTP? And the answer is really any patient who's already undergoing PGT. And PGTP should be used as an adjunct to the testing that they're already getting. It's an addition to, not a solo test. And with that said, no family history is needed in order for us to get this testing because we all have a risk of polygenic disease. And so one of the questions that I always get is it important for somebody to share a history of a condition in order for us to be able to order this testing? And the reality is no. The idea is that we all have risks for all of these polygenic conditions. And what this test is doing is assessing whether the risk is higher or lower, but it's not related at all specifically to our family history. With that said, though, traditionally, we do get a lot of questions from people who have a specific history of these conditions. And one of the conditions that we get asked a lot about is whether we can screen for type 1 diabetes because they're concerned because they already have a child with type 1 diabetes or because they themselves have type 1 diabetes. With that said, what about a strong family history that's suggestive of a monogenic condition? So for example, if I'm talking to a family and we're concerned about, let's say, breast cancer, and that couple knows that we're able to screen for breast cancer using polygenic testing, but in that conversation, they share with me, oh, my mom had breast cancer, my sister had breast cancer, my aunt had ovarian cancer. As a genetic counselor, the first thing I'm going to think about are hereditary cancers. And so it's very important that if there's a concern about a hereditary cancer syndrome, that be addressed in the exact appropriate way prior to considering PGTP. Because if there is a hereditary cancer syndrome in that family, it's really important that they have the opportunity to get testing and have PGTM if PGTM is really what's indicated for them. And so it's important to remember that PGTP is not a replacement for PGTM. And the other concern or other question that people ask about is, does it matter how many embryos a patient actually has? The answer is yes, it absolutely does, actually. And it's very different than PGTM testing or PGTA testing because those tests are done essentially individually on each individual embryo. But when it comes to PGTP testing, we're really not looking at each individual embryo as much as learning about the cohort of embryos together and identifying which embryo in that cohort has a lower chance of polygenic disease compared to the other embryos in their cohort. So the way that I would counsel a patient who is, let's say, 42 and maybe has low ovarian reserve and maybe is expected, hopefully, to have maybe one euploid embryo is going to be very different than counseling a couple who's maybe using an egg donor that's 20 years old and is expected to create multiple embryos. The latter example is an example of a case that's better suited to polygenic testing compared to the first example. And so, and I can't reiterate this enough, this test is best used as a tool for comparison and selection, and the data supports that as well. So for example, in a study that we published back in 2019, when we looked at relative risk reduction and actually calculated and measured risk reduction, and relative risk reduction really is, that's the goal of polygenic testing. How well are we able to reduce the risk of conditions if we're comparing embryos using polygenic risk scoring? And so on average, the relative risk reduction for type 1 diabetes when we compare two embryos is on average about 46%. But if we have the opportunity to compare 5 embryos, on average, the relative risk reduction is about 72%. So the testing essentially, in other words, is more robust if we have more embryos that we're able to compare. Another concern, another question that we get asked a lot about is diversity, and whether this testing can be offered to all individuals. How is it different compared to different ethnic groups? You know, where does it work better? Where does it work less well? And so it's well known in the community that studies polygenic risk scores, that polygenic risk scores are primarily derived and tested in individuals of European ancestry. And the predictive power of this testing is reduced in individuals from other ethnic groups. What does that mean from a practical perspective? If somebody were to order this testing right now? So this is the different group of diseases that we're able to screen for currently using our current polygenic panel. So type 1 diabetes and certain cancers, cardiac risks, etc. And if an individual has Caucasian ancestry, that is the list of conditions that they will see on their specific report. The difference is in other ancestries, because we have less data in individuals with other ethnic backgrounds or different ethnic backgrounds, we don't have enough data to support the validation for reporting certain conditions. And we're only going to report conditions that we validated and have enough data to be able to support reporting. And so, for example, if an individual has South Asian ancestry and I'm speaking to them, I'm going to let them know that the conditions that we can screen for are the ones in orange, but the ones that are gray now are the ones that we're no longer able to report on. And that's the case for East Asian ancestry. That's this list. And African ancestry and Native American and Hispanic ancestry. And so the take-home message is that when we're thinking about polygenic testing and ordering this testing, we're able to order this for everyone. So everybody has access to PGTP, regardless of ethnic background. Everybody will be able to get this testing and get an embryo health score. But the list of diseases on the back of the test will look a little bit different depending on ancestry. Another concern and something else that I hear a lot about when it comes to polygenic testing is sort of this idea of risk reduction versus what we're used to with PGTM, which is diagnostic testing. And so with PGTM, we're used to this idea that we order this testing, we're able to determine whether an embryo is heterozygous positive or negative or homozygous positive or whatever the genotype is for that variant or set of variants. And then we can see whether an embryo is going to have or not have that condition. And that feels really good, you know, from a clinical perspective, because it can give patients, you know, and ourselves very clear information. And that it's always, of course, better to have clear information than not clear information, just like the conversation everybody was just having about, you know, segmental aneuploidies. So we like to live in this black and white state versus in this shade of gray state. And polygenic testing is very different. Polygenic testing is our, you know, it's a different idea. It's the idea of looking at a cohort of embryos in an effort to reduce the risk of these conditions. But by no means is this testing giving a black and white answer saying, yes, this embryo will develop type 1 diabetes, for example, or no, this embryo won't develop this condition. So it's very different. But with that said, I would like to point out that PGTM is commonly used in this current day for risk reduction. And we don't really necessarily think of it in that way, but it's very common for us to get inquiries in our laboratory to screen for genetic variants that may have low penetrance, that may have variable expressivity, that may not be characterized as pathogenic, but may be considered variants of uncertain significance. These are all things that change the scope of testing from a yes and no answer to a higher versus lower risk answer, even under this PGTM umbrella. And the example that I use all the time and that I think about all the time when it comes to this concept is cystic fibrosis. And the reason I bring up cystic fibrosis is because this was the first real clinical use of PGTM way back in, you know, the 1990s, after, you know, the initial use of sex selection to look for certain monogenic diseases. This was really the first true use of using linkage analysis to identify the presence or absence of variants. And this was a case where both members of the couple were positive for a Delta F508 variant, which is a classic variant, and they were screened, and the embryos were screened to see if they were positive or negative, and that was sort of the end of that. And so from that, way back in 1992, we really don't blink an eye very much when we get referrals or we refer patients for PGT for cystic fibrosis, because we consider that sort of a classic example. But since the 90s, cystic fibrosis, what we know currently about cystic fibrosis has changed dramatically. There's thousands of variants that have been reported, and I would argue that most of those variants, though, especially the recent ones, are really more mild in origin. So for example, a couple may be at risk for not classic CF, but mild pancreatitis, or they may be at risk of having a child with male factor infertility, but not necessarily classic cystic fibrosis. And so if we're looking at these mild variants, some patients would not necessarily not transfer those embryos that are compound heterozygous or, positive, but rather they would use this as a tool for triaging their samples, for organizing their samples, because they may consider transferring an embryo that's positive for both because the symptoms are more mild. They would prefer not to, which is why they're doing the testing, but it wouldn't mean that they wouldn't transfer an embryo. So this idea, when we're looking at these mild cystic fibrosis variants that are not associated with classic cystic fibrosis, or maybe not cystic fibrosis, or, individuals may be asymptomatic, it's more in line with the idea of PGTP than maybe we think about typically. Another example of that idea is BRCA testing, BRCA1, BRCA2, another group of conditions that clinicians don't really bat an eye when they refer patients to us. So for BRCA1, for example, we consider this a high-risk variant. Women that are, born with a BRCA1 variant have about a 50 to 80% chance of developing cancer related to that genetic variant. And so we're commonly get referrals for this variant. But what if we change the variant to a more mild or moderate risk variant, like an ATM variant? These variants are very different. They're not considered high-risk variants, but we get referrals for this type of testing all the time, where an individual is a carrier of an ATM variant, and that means that if they're female, that they have about a double risk of breast cancer compared to individuals that don't have this variant. So instead of 12%, the risk may be around 24%, 20 to 24%. And so again, this is a tool that couples are using to triage their samples. They wouldn't necessarily not transfer embryos that are positive, but want to use that information to be able to assess risk and make a decision about how to prioritize an embryo, which sounds a lot to me like how the information from PGTP can also be used. So to wrap everything up, it's important, with that said, and even though we're I just gave an example of us using PGTM, as a risk reducing tool, ultimately these are tools that are designed and to be used in very different ways. And PGTP is not a replacement for monogenic testing, and we talked a lot about that, and that's extremely important. But rather, I would say that PGTP could be considered as an adjunct, not to PGTM, but really to morphology-based selection. So in the current use of PGTA, for example, right now, couples have, or individuals have PGTA testing. They look to see at the number of embryos they have that are euploid. And then of that cohort, they may then say, well, which of these embryos now looks best when it comes to morphology? We would say that now PGTP can also be used in that same vein. Once we have a group of embryos that are considered to be euploid, then how do we use the polygenic data to be able to say, okay, let's prioritize this embryo for transfer? So with that, I'll stop so I could also help participate in answering any questions that anybody may have.
Muchísimas gracias, Jennifer. Muy, pero muy interesante la charla sobre...
Thank you very much, Jennifer. It's been very interesting, your presentation on PGTP. We are all very interested in this topic. I have already introduced the discussant, and we also invite the participant, the audience, to make questions. Now, Cecilia and Sebastian have the floor. Thank you. Seba, would you like to start? Jennifer, thank you very much. Thank you very much for your presentation. We always learn a bit more about PGTP. It's not simple. Seba, would you like to start? Yes, I have a question for Jennifer. If the ancestry that you showed in the slides is always self-perceived ancestry, or do you do a molecular study to define it, considering that there are mixtures, ethnic mixtures, some individuals can be adopted, and have you incorporated that type of studies to PGTP?
That's a really great question. And the answer is yes. There is, as part of the quality control metric for the PGTP testing, we do include an internal ancestry check. It's not something we're reporting. We're not trying to do the same things that other laboratories do when people are interested in learning about their ancestry. But really what we're trying to do is make sure that if we're reporting a certain cohort of conditions, that we're able to, because it matches the self-reported ancestry, and therefore we're reporting as accurate is not the best word, but as accurate data as possible. So we do perform an ancestry check and make sure that the self-reported ancestry matches the ancestry from a genetic perspective. Absolutely.
Ceci, no te escucho.
Perdón, estaba silenciada esta. Jennifer, tengo una
Jennifer, I have a curiosity from my experience to know how you manage, although you give a score that is the embryo health score, you also give a list with the score and the specific risk for each condition that you can report. When a couple is interested in, for example, is more interested in type 1 diabetes, but the embryo that has the lowest risk for that condition has higher risk for the others. How do you manage the situation? I don't know whether this is frequent or not.
Yes, that's a really good question. And it's something that we've struggled with in terms of designing the test, because it is absolutely possible for the condition that might be of most concern to not necessarily, to be a little higher, but that embryo maybe overall have a lower score, just like you described. And a lot of the times, especially for conditions that are more rare, because they don't count as much in the total score, conditions that are more common and more severe carry more weight. Conditions that are less common or less severe carry less weight. So those scores are weighted. Type 1 diabetes, as an example, is a condition that's much, much rarer compared to the other conditions in that group. Breast cancer is more common, and coronary artery disease is more common. So if there's a little bit of wiggle in that score, it may not be reflected in the overall score as much. So we weren't quite sure how to combat that. And so we always, originally when the test was being designed, we thought, well, let's just have the embryo health score. Let's not give all that stuff on the back. But it would mask some potential, conditions that maybe, just like you said, a couple may be more interested in. And then if we were to only give those numbers and not give the embryo health score, it would also make it difficult to make a selection, because how do you put these numbers together? We're not helping with that. So ultimately, it really does depend on what the couple is interested in and how they're going to use the information. If a couple is only interested in type 1 diabetes, as an example, because they have a child with type 1 diabetes, we do have an option for them to just order testing to screen for type 1 diabetes. That way, they don't have to worry about the other information if they're not interested in it. So that's one way we try to help that issue. If a couple wants to get all of the information, though, but they're still particularly concerned about type 1 diabetes, they may decide not to go select by the embryo health score, and they may decide to go by just the type 1 diabetes number, because that might be for them their, concern point, and that's okay. That it's okay to do that. So it does become a little bit difficult, but ultimately, and this is why, the genetic counseling and the discussion with their own clinician is so important. Ultimately, it comes down to making the selection based on what the concern is. Certainly, a couple raising a child with type 1 diabetes will certainly have that condition on their minds when they're making their selection. There's, based on, their own history and their own experience.
Ok, entiendo. O sea, en definitiva, puede pasar, la pareja tiene que
I
saber.
understand. The individual who's doing the study has to know that they will have to make the decision of what to prioritize. There is a question from Marcelo Dominguez. The average 70% implantation rate of euploid embryos by PGTA could be explained by heterogeneity of the methods and technology used. I understand he talks about the perhaps the low success rate, or cases in which there is no implantation that could be explained by heterogeneity of methods. Perhaps this is, Marcelo, what you aim at, or maybe you can add something in the chat. Then I answer. So it's clear that the majority, when we talk about aneuploidy or genetics of infertility cause, the embryo factor, we cannot say that 70% of that black box of 70% was heterogeneity, because we have endometrial factors, many other things. It's true, the endometrial factor, the latest studies are saying it's not as prevalent as we used to think, and we can control many things with the patient. But no, I wouldn't say that 30% of non-implantation that is justified by heterogeneity. I would say the variability of success rates with PGT in different centers with different platform. Why? Because we know that the studies where they compare different platforms, we talk about 60% or 65, 70%. So if there is variability justified by that heterogeneity, well, depends on the study, but 5 to 10%, which is quite a lot for us. But to say that 30% of the is based on PGT, well, we have endometrial factors and the transfer technique. Sometimes, well, that depends on the physician's skill. Well, we could influence a little, but not does not have the highest weight. Raúl Ina Aguilar, for you, Diego. And it says, could you comment on the coverage of NGS in PGT and false positives in aneuploidy of whole chromosome and deletions or duplications? Well, I will make a general comment because the sequencing platforms are very different. Some platforms do what is called low pass, in which what we do laboratories to optimize resources. So they run more samples than they should, or what is recommended to make it more practical. So you have a lower number of readings, and then you start to see what is noise, what is not noise. So I think the question goes in that direction in terms of coverage. Like what has been published, that about 20,000 positions in the genome have that when a platform like a SNP microarray, we talk about 200,000 positions, the new 800,000. So it's a bit more for comparison purposes, but with respect to the false positives and negatives, it's that when we have what is noise, what is not. The advantage of SNPs is that we have extra data that helps us to confirm, but the origin of the SNP should not be in the SNP array. We can incorporate it in NGAs with lower resolution. When we do the targeted amplification, we can have 4,000 SNPs, not 800,000. So there's where we see the difference. In general, from based on the experience, when NGS with complete aneuploidy, it is believable the result even with low coverage. But when there is noise, yes, there may be a false positive, but complete aneuploidy, it usually continues to be, the technique continues to have a good resolution. It is true when we start to see 4, 5, 6 aneuploidy, that's something different, because we are seeing something more complex, chaotic. Well, that's another topic. We have seen biopsies, many are euploid, but well, yeah, that's noise. Thank you. Well, I want to make a more clinical question for Jennifer. In your experience as genetic advisor, I'm interested to know if you can give us an approximate percentage of patients that decide to do PGTP, or the number of doctors that refer patients to do PGTP. It's high, low, how much is it being used?
Good question. I would say it's definitely not high. I would say that right now it's still in its infancy. And we do have a number of centers that are starting to offer this to patients on a routine basis. And we definitely have patients that are coming through our centers that are requesting this testing and who are choosing to have this testing. But globally, I would still consider this a small number compared to the amount of centers that, send us samples for PGTA, for example. With that said, we did just recently close out a study where we were interested in learning exactly what you just asked. If patients are offered, if this is made available, how many patients will say yes to this testing? So we offered this to patients, a little over 200 patients, I think, in one center. So they were essentially offered it in the same way. We had the opportunity to perform genetic counseling, and they had the opportunity to say yes or no to this testing. And it was about half of patients that said yes and half that said no. So I think some of the barriers right now are have more to do with sort of making the testing available, to a wider audience, and a wider number of patients. But it was very interesting to us to be able to see that and say, see that when we are able to sort of control and say, okay, here's one center that's allowing us to offer this in a research setting, how many people would be amenable to it?
Buenísimo, me encantó la respuesta. Y bueno, ese estudio que hicieron, excelente.
Well, excellent that you did that study. I think we are on time. If we have time for more questions. Well, it is very interesting on the topic. The speakers are wonderful, but we have to close. At least for today. We can continue some other time, but today we need to close. I'm sorry. And the truth is, we are very grateful, Diego, Jennifer, Cecilia, Sebastian, Andrea, and all those that accompanies technicians, faculty that works extensively to organize the meetings. Thank you very much. Now, an announcement. Sehir is turning 40 years, making history and helping patients. And a part of the celebration will be an event October the 4th, so you can save the date. It'll be an in-person campus meeting, and we will discuss preservation of fertility. So it'll be very interesting in person. We will have more information to offer in our web page shortly, but at least I wanted to let you know the date so that you save the date. Again, thank you very much. We could continue talking for a long time. I'm sure Cecilia has many questions, Sebastian, Andrea the same, but at some point we have to release the speakers. So thank you very much for being so kind with us and share your knowledge, your time, and your friendliness. Thanks a lot. We'll see you soon.
Thank you.